All right, it's Paul again. I'm going to be talking to you about neurologic problems, but first we're going to start with a review of the nervous system. So just very quickly, you recall that neurons are the central unit, and the neurons have an important component that no other cells do, and that is the Schwann cell that surrounds the axon. This is the insulation, essentially, for the wiring that is the nerve, and major problems happen when there's demyelination or loss of that myelin sheath. Neurotransmitters are how things happen in the nervous system, and so the communication from one neuron to another or from a neuron to the neuroeffector cell on the other side of the synapse is how the neuron communicates with other cells. The divisions of the nervous system you should know, but I'll just review them again. Of course, there's central nervous system and the peripheral nervous system. The central nervous system consists of the brain and the cord. In the peripheral nervous system, we have two divisions. They're motor neurons and sensory neurons. So obviously the motor neurons do all the functional stuff as far as movement and connection with glands. And then the sensory cells allow you to feel, and of course that includes things that you wouldn't necessarily think of as feeling, such as proprioception, which we'll talk about later. Then for the motor neurons, there's a subdivision into the somatic nervous system. That's the stuff you can control by thinking about it. And the autonomic nervous system, which controls involuntary responses. And of course, the autonomic nervous system is divided into the sympathetic, fight or flight, and the parasympathetic, rest or digest. There are also divisions of the cerebrum that we should talk about, and you probably know some of these, such as Broca's area, right? That's a language center. Wernicke's area is another language center, which is located back here. And then we have a couple of important divisions like the somatic strip and the sensory strip. The motor strip is what we refer to this to as, and the sensory strip here. Cranial nerves come off and directly innervate certain structures. We know about the first cranial nerve that is the olfactory nerve. We kind of skip that when we do the assessment, right? Because it's hard to test that unless you have a packet of coffee with you or something. And good neurologists always do. So these are the cranial nerves that innervate specific organs. Some of them are sensory, some of them are motor, some of them are mixed. This is the homunculus. The homunculus is a way for us to think about what is innervated in both the somatic motor area and the sensory area. So the motor strip, which is here along the cerebrum, begins on the inside sulcus, right? So on the inside of where the two hemispheres join. And when we start here at the motor area, the very lower part here controls the toes, and then the ankle and the knee and the hip and the trunk and the shoulder and the upper arm. And notice how much of the brain is devoted to just the hand and just the thumb. I mean, that's a huge amount, just so that we can properly innervate the thumb and hand and have good control, as opposed to the elbow, arm, and lower arm, which take up just about the same amount for that entire structure as just the hand does. And then similarly, you can see the funny looking guy here and the important innervations for motor function. On the somatic side, we have the same deal. So genitalia begins this, and then we have foot, toes, legs, hip, trunk, etc. Again, the hand has a lot of sensory function, as does the face. The lips, teeth, gum, and jaw have a huge amount, and then the tongue, pharynx, and intra-abdominal structures. Now, the way that the peripheral nerves communicate with the central nervous system is through the spinal cord, right? And so the spinal cord has divisions as well. And there are tracts that are sensory, which are shown here in blue, and motor, which are shown here in red. The motor pathways then and the sensory pathways have to communicate with the brain. Otherwise, what's the point, right? And so these tracts lead up to the cerebrum so that processing of that signal can happen. The difference between the sensory pathway and the motor pathway is that the sensory pathway goes through the thalamus, and the motor pathway skips that. So the sensory pathway has to go through the thalamus in order to direct that signal to the correct part of the cortex. Now, this is really important that you remember the reflex arc, and I'm sure everybody remembers that when you touch a sharp tack, your arm pulls away and everybody lives happily ever after. That is the reflex arc, but that's not the important part that I want you to remember. Step 3 here is really critical. So what happens when you touch a painful stimulus is the signal gets transmitted through the dorsal root to the neuron here that sends it in two directions. It sends the signal first through the ventral root to the neuroeffector junction, and the response is that you pull your hand away quick. But the other thing that happens is that it communicates with the brain. And so it sends this signal up to the thalamus so that it can interpret the signal and temper the response a little bit. So people who have upper motor neuron lesions, that is the brain or spinal cord being involved, tend to have hyperreflexia because this part is broken. It doesn't communicate with the brain. The brain can't tell the reflex arc, okay, you're touching something sharp, just calm down, pull your hand away, everything's cool. And so the reflex arc just has this part to it, and that means that it's a hyper-reflexic response. We're going to talk more about that later on. There are protective coverings of the brain and the cord, so remember that the skull houses everything, and then right below the skull is the dura mater, and then the arachnoid layer, and then the subarachnoid space, which has the cerebrospinal fluid bathing it, and then that is has a base of the pia mater before you get down to the brain tissue. So those are the protective layers of the brain, and the cord, by the way. So CSF production happens in the brain through different mechanisms, but the choroid plexus is where any of these actually is where the CSF is produced, and then the fluid also has to circulate through here as well. And if there's a blockage in any of these sinuses or in the villus, the arachnoid villus or any of these places, you can have buildup of CSF fluid. And of course, along with the buildup of fluid comes increased intracranial pressure. This is another picture that helps illustrate the divisions of the spinal cord. I just want to take a moment to point out something important. All of these structures are very close together, and this was illustrated to me one day when I was with a customer who happens to be a neurosurgeon, and I saw an image just like this up on the screen, and he was about to go in and see this patient, and I couldn't believe what I was looking at, because if you take a look at this, here you can see hardware that's screwed in. This is just a screw that goes in through the vertebral body to keep this all assembled together. But look where that screw goes. This is insane. So this is the cord right here. So if you put that screw in just a little bit off, you're going to hit the cord. But this hole right here is actually the vertebral artery. And so if you put that screw in just a little bit off to this side, you're going to hit the vertebral artery and the patient will have a stroke and die. This is amazing to me that these guys put these screws in like this. I can't even put a screw in the wall in my house without going crooked. So next time you meet a neurosurgeon, you should shake their very steady hand. So let's talk about the circulation. This is a quick little schematic of how the brain is supplied with blood. And so from the aortic arch, we give rise to the brachiocephalic artery on the right side. And on the left side, remember, it's divided into the left common carotid and the left subclavian. So these are the three vessels that come off of the aortic arch. From there, the vertebral artery comes off of the subclavians. All right. And that vertebral artery goes up through the vertebrae, like I showed you here. These are the vertebral arteries. And then they go up and form the basilar artery, which goes to the circle of Willis. So this circle right here that you see is the circle of Willis. And the circle of Willis is important because if you have a blockage in any of these, like in the posterior communicating artery, for instance, theoretically, the blood can get everywhere else that it needs to by going around the circle, right? So that's the design, at least. Now, that has varying effects when you're, based on your age when you have an event. The very young and, I should say everybody except the very old tends to not really have a very adequate response. But older people, for some reason, seem to be a little more resilient, and they tend to not have as severe reactions. And what I mean by that is that an occlusion somewhere here along the circle of Willis doesn't necessarily kill them. They may have terrible, devastating injury from that, but it doesn't typically end their lives. It does if you're like a middle-aged person who has something like that happen. And it's very strange. I don't understand that, but it's the way it is. Anyway, the circle of Willis then has important things that happen. One of them is that the middle cerebral artery comes off here. All right. So the middle cerebral artery is actually the artery that supplies blood to most of your brain. So if you put your open hand along the outside of your head, that's essentially, right above your ear. That's essentially the distribution of the middle cerebral artery. There's other arteries here too, like the anterior cerebral artery and then the posterior cerebral artery as well. Those are the three main vessels that supply the brain: anterior cerebral, middle cerebral, and posterior cerebral. And then there's many others that come off of that as well. Spinal arterial flow goes from the basilar artery down through the other vessels that are shown here. Not as important that you understand this for most of what we're going to talk about. The sympathetic nervous system we started to talk about earlier when I introduced the concept. Remember, this is fight or flight. These are the innervations that count for the sympathetic nervous system, and the parasympathetic nervous system is shown here. The other thing that we talk about all the time, but is not necessarily well understood by most students, is this thing called the blood-brain barrier. And this is a representation of what happens in the blood-brain barrier. In normal blood vessels, there's there are pores in the vessel that allow for flow of lipid-soluble substances, but also of fluid, like edema, for instance. Now, with the blood-brain barrier, there is a barrier that prevents those lipid-soluble substances from coming out, and there has to be some carrier that takes the substance from inside the blood vessel and sends it through that blood-brain barrier. They have these tight junctions with no pores, so things can't just leak through this blood-brain barrier, and that causes an issue for us, right? There are certain substances that we can't get across the blood-brain barrier. That's a good thing in some cases, but it also limits our therapies to things that can't cross, prevents us from using things that can't cross that barrier. The next thing to talk about is this thing called the Monro-Kellie Hypothesis. And essentially what this is this is all the fanciful stuff, but let's talk about it this way. Let's just think about the brain in a box. So what this hypothesis says is that when we have a patient who has increased intracranial pressure, the reason that happens is because the brain lives in a box. The box is the skull, and it's filled with brain tissue, blood, and CSF. Those are the only things that are part of it. And when we increase any of those things, whether it's brain tissue because we have a new tumor growing, or whether it's increased blood because they're bleeding into the brain, or whether it's increased CSF because they have hydrocephalus, any of these things can increase the intracranial pressure if we don't compensate by removing one of the other items. So if you have bleeding into the brain, for instance, sometimes we need to take off some CSF and just to normalize the pressure in there. Sometimes that's not enough. We need to do something else, and we'll talk about that later as well. Cerebral perfusion pressure is an important concept for you to remember, and you have to know how to calculate it. It's the mean arterial pressure minus the intracranial pressure. And so you can see that as the pressure increases, as the intracranial pressure increases, the cerebral perfusion pressure will decrease given a constant mean arterial pressure. So a normal cerebral perfusion pressure is like 70 to 90. With some ischemia, you get or with a pressure that goes down to 50, you get some mild cerebral ischemia. When the cerebral perfusion pressure gets down to the same, or equals the map, I should say, there's no gradient, and so there is no blood flow. And that's one thing that happens in severe trauma. You get this no flow phenomenon where the pressure in the head is so high that the blood can't flow into the cranium, and therefore the brain gets no blood supply. The last thing to talk about here is autoregulation. So when you have a patient who has a stroke, for instance, we are very concerned about regulating their blood pressure, because the blood pressure affects, the mean arterial pressure affects the cerebral perfusion pressure. And autoregulation is the brain's ability to regulate that. So when we have decreased cerebral blood flow, that is due to vasoconstriction in the brain, and increased cerebral blood flow is due to vasodilation. The body regulates that by itself. And so we have to know about that. When we decrease the blood pressure too much, we may actually make it hard for the body to get enough blood to the brain, because the brain responds by either vasodilating or vasoconstricting based on the blood pressure. I know that's a complicated thing to understand, but just know that we have specific parameters that we use so that we don't overcorrect. One last thing to talk about is cerebral metabolism. Remember that the brain is an oxygen and sugar hog. It can't store either, so it has to be constantly supplied with it. And so if you have an interruption in blood flow, then that's going to have deleterious effects on the patient's survival.